All right, Chapter 58, EMS Deployment and System Status Management. Now, for most of us, deployment occurs through a communication center. We're dispatched via pager and respond appropriately. In some higher functioning systems, there is a science or an art in EMS deployment using system status management. Now, if I get this to advance to the next slide, we'll be doing good. There we go. Some key principles of the EMS system. Has to be accessible, easily accessible, and of course, in the United States, we've got 911. In other countries, it's 811. In other countries, it's 411. We've got 911 here in America, and that would ensure easy access by a number that's easy to remember. You have to have an appropriate response. In other words, responding with the right vehicle, the right crew, in the right amount of time. This requires planning and managing where you're going to place the ambulances to get the biggest bang for your buck. Now, again, for most of us in rural America or rural Iowa, ambulance management placement, it's either in the fire department or at the hospital or potentially a county shed. Where when you're dealing with larger cities in Iowa, ambulances use this system status management. EMS deployment and system status management, again, is an art and a science of matching production capacity to the changing patterns of demand. And that's being able to anticipate and prepare for the next call and where that might be. It's an art in the sense that it's hit and miss, and it is a science based on data that's been collected in large systems and analyzed to determine times when call volumes are higher, things that may occur in a community that would increase call volume, those sort of things. Much like ragbris coming through a particular town, we know what that's going to do. You can have fixed station deployment, and here's a map of a larger city showing fixed sites where ambulances would be stationed permanently and waiting for a call. You can have a combination of geographically located stations as well as demand posts, and the red would equal the demand posts, where if necessary they could dispatch from those areas. Fully deployed, these are situations where units are assigned to a street corner. They're not in a building, they're not in a station, they're just sitting at a street corner waiting to be dispatched. This does eliminate shoot time, and shoot time is the amount of time it takes you from the time that you're paged to get to the vehicle and on the road. Deployment should be flexible because there's no sure way to predict when and where an ambulance will be needed. So we've got to have some flexibility in our ability to deploy. Some deployment factors include geospatial demands, and geospatial has to do with the geography. Where what the roads are like in that particular area. Is it urban or rural? Those sort of things, as well as temporal demands. Now, here's an example of the units on duty is the pink line, and the ambulance demand is the purple line. And you can see that when you map the two, that you can have a consistent number of units on duty but their demand is going to at times be less. You don't need that many units on duty, and at other times you don't have enough units to handle the demand. So EMS is pulled in multiple directions when we talk about this topic. Supply and demand. Supply would be the number of vehicles you have available to respond. Demand, of course, would be your call volume. And that in part is determined by the amount of funding that you have available to purchase vehicles, staff vehicles, and and then satisfaction is part of this as well. Many services are if you're hospital based, you're already participating in some sort of patient satisfaction survey. Other services are sending out patient satisfaction surveys to make certain that people are happy with the service that is being provided. The history of deployment. Jack Stout out of Tulsa, Kansas City, about 25 years ago, analyzed ambulance calls, and based on where the calls were occurring, he created demand maps and plans of where to station ambulances and how to deploy them. Jack became very famous as a result of this and was in quite demand in many big cities across the United States in helping them establish status deployment plans. Here is a map on the front of this communication center, and you can see that this is an old communication center based on the type of equipment that they're dealing with, but also in its day it was quite modern in the sense that they were mapping where vehicles were and where their needs were, and changing where they position vehicles based on a day-to-day flex. Computerized deployment plans were created. They were data-driven. They took a systemic approach. And again, I had mentioned they moved ambulances frequently. It made longer shifts detrimental. It led to unpopular street corner deployment. Ambulances just hanging out at different street corners gave the public appearance that, they didn't have anything to do. We all know that in EMS there can be a significant amount of downtime. And when you set yourself out on a street corner and don't move for 8 hours, public had a certain concern about that, especially if the ambulance was tax-based. Workload management, planning resources and support around demand, which was temporal modeling. They looked at or anticipated what the demand would be. And we do this to an extent, and I mentioned RAGBRAI as an example. We can plan ahead of time when we know certain events are going to occur. Staffing, concert staffing, special events. We do shift and move resources around as a result of those things. Now, modern deployment also has to consider, in addition to the workload, the resources, things like balance coverage. In other words, not having a part of the city where a vehicle might sit for long, long hours and never be deployed, and that's the day-to-day norm for that particular service, as opposed to other services or other ambulances within the same service being really, really busy or being in a really, really busy part of town. They also have to take into account response times or that shoot time, because that's an important factor that the public is really concerned about. And then the satisfaction of the crew. when they were doing those street corner deployments, some of those crews had to stay on those street corners for extensive amount of times, and it led to really long shifts with few breaks and crew dissatisfaction. And when we look at the basic principles and practices of a deployment, we use this fish diagram. Again, it's all based off of demand and supply. But you can look at the workload management, the things that have to be considered concerning workload management, like training and education, peak load staffing, personnel management, logistics. And logistics is, not only tangible items like bandages and dressings and IVs and drug kits, but also human resources as well. Recruitment, workload modeling, shift design, fleet management, all that goes into the workload. And dispatch, you've got call taking and transfer, accurate call details to the crew, call prioritization, driving safely, route selection, shoot times, resource selection, do we send BLS or ACLS, and training and education of the dispatchers. And then you go down to modern deployment, and you've got management and staff training, work modeling, deployment plan development, CQI, deployment plan implementation, staff consultation, workload data collection. So all those things are part of a modern deployment system. Then you can look at your own systems and how they're dispatched in services where you work and see what part of these things are actually occurring, and would any of these other things, that if they aren't occurring, would they help you provide better response? So some factors to consider when dealing with modern deployment include response times, the level of care, whether it's BLS or ALS, population density, geographic density, call demand patterns, call acuity, and that's how sick are the people when they are calling, the road systems and the how well the roads are maintained, whether there's torn up roads, detours, those sort of things, and then where in relationship are you to the healthcare facilities in your area. Dispatch factors include, rapid call taking, call prioritization, pre-arrival instructions, as we've talked about with emergency medical dispatchers. Rapid call taking and call prioritization will reduce shoot time as well, and will reduce hospital offload times. That's the amount of time that you spend at a hospital once you deliver the patient there. Measuring unit hour utilization, you divide the number of transport by the total unit house available. That should be unit hours available. And time on task deals with the average time committed to manage an incident, to include your offload delays. Offload delays, as well as I do, that when you bring a patient to a hospital, you may not be able to get them off your cot right away. You may have to wait for an open bed. You may have to take the patient to another department, and so you may be delayed in the hospital for some time before you actually can leave the hospital and be available to respond to another call. Schedules, shorter shifts can tolerate higher unit hour utilization. So, if you work an 8-hour shift and you're running 12 calls, that's going to be a really busy shift. But that's something that you could handle. If you're running a 24-hour shift and you're trying to handle 36 calls, that's just too much for anybody to deal with in a 24-hour period. So the importance of unit hour utilization is it demonstrates the value of your service for the greatest value for a fair price. Pricing and what we charge for the service is variable all across the state. I know directors of ambulance services do a good job of talking to other directors and finding out prices and what's being charged, and that sort of thing. You can charge all you want. The vast majority of the calls are Medicare, Medicaid, and they're only going to pay so much. It's the the middle class payers, with or without insurance, that end up paying the brunt of those responses. So it's important that you're able to demonstrate that the service that you provide is a great value for the price that you're charging. Funding, 55 to 80% of all the ambulance budget goes directly to personnel. The most expensive aspect of EMS are its personnel. You've got to have adequate resources to achieve target response times. In other words, you got to have enough people in the appropriate location that when a call comes in, that you can get there quickly. And achieving target response times and deployment methods used are primary determinants of cost. The more staff you have, the more expensive your budget is going to be. It's important that, not necessarily important, but something to consider is, we got into EMS to save lives. We got into EMS to help others. We got into EMS to make a difference. But EMS is a business. It's an industry. It's a business. It's the business of people. And because it is the business of people and you're dealing with lives, emotions can be high. And one of the last things that we think about is cost. And what does this cost? And how can we be more cost effective? But all that has to be considered by someone within the organization in order, depending on the given situation, to either be profitable, like with private duty ambulances, or at least break even with municipal ambulances. All ambulance companies would like to make a profit, because you take that profit and you dump that back into education, training. You take that profit and dump it back into purchasing of new vehicles and equipment. So profitable would be good, but that's a major struggle in most EMS systems. Issues that affect success and satisfaction. I already mentioned that your response time is a huge factor that is scrutinized in many communities. You can measure your response time against other accepted benchmarks, and there are things called fractal response times as well. And I'd have to look up just exactly what that is referring to. And then we already talked about the UHU and how you can use that to measure your system's productivity. Productivity is, as a hospital-based ambulance service, every month we get a productivity report. And the productivity report is based on FTEs, full-time equivalents. There is a formula that's used to determine that based on your call volume, based on this, that, the other thing, it would take this many full-time equivalents to do that job. And so based on the FTEs that you have available, how productive are they? And we're required to maintain above a 90% productivity standard. So staffing 90% efficiently. Ideally 100% would be the goal, but that's difficult, because when we start having long transfers and paying overtime, that actually decreases your productivity and not increase it. Resource control, that requires functional control of field units and dispatchers following the plans and protocols that have been put in place. Human factors, I touched briefly on this already. We are in the business of people, and it's unreasonable expectations of management and field staff you'll run into this classic clash all the time, that people in management don't understand what's going on in the field, and that when management makes a change, they don't consider how that change affects the people in the field. And so one thing that most of us in EMS do not like is change, and especially when we have no control over that change. We have a tendency to be control freaks. I know I am. And when I'm being told I have to do something without any sort of input, or with my belief that the people above me didn't take into consideration what those changes would do to staff, or how it would affect staff, there's where you get your clashes. Some other human factors include getting your crews to commit to develop and follow a plan. That can be a challenge as well. And ways to eliminate that is to keep staff informed, keep them engaged in those decisions, keep them informed of changes that are going to occur and why, so that they have a better idea of the bigger picture. So give them that baseline knowledge. Give them the equipment that they need to do their job successfully, staff adequately, and your best, or any business's best asset are its employees. So here's some things that occur during an ambulance call. The 911 phone rings. That's T-0. Call is transferred to a medical call taker, and then the call location and pre-alerted to the dispatcher, and then the ambulance is notified. The ambulance is en route. There's your shoot time. The ambulance arrives on scene. That's your travel time. The crew departs the scene. That's your treatment. And then the crew arrives at the medical facility. That's your treatment as well as your transport time. And then you're available to go on another call. EMS system response time is from the time the 911 call is picked up until the ambulance arrives on scene. And that is highly scrutinized. And I know even in volunteer services, people look at what ways can we do to get out the door quicker. Certainly driving fast to get to the scene isn't an answer to shaving time, but assessing faster, treating faster, being more efficient with the care that you provide are things that certainly can be done to address that. All right, so if you have any questions, you know how to get a hold of me, and I will talk to you soon.